As far as hip and pelvis pathologies are concerned, we can recall that the hip is often affected by degenerative pathologies, such as the hip osteoarthritis, or by the insertional tendinopathy of the abductors and external rotators, with or without trochanteric bursitis. The pelvis, instead, is more often affected by overuse disorders, like the adductors syndrome, or pubalgia, which is an insertional disorder affecting the tendons of the adductors and of the gracilis and the recti abdominis at this level, that is to say, in the area of the pubic insertion. The examination of a patient affected by pubalgia consists of assessing by palpation the insertion in order to locate exactly the insertional painful point, both in the adductors and in the recti abdominis, in the pubis. Such a pain can be either localized or irradiated distally along the thigh, in its medial aspect, and it can be increased mainly by external rotation, passive abduction, and adduction against resistance. Another movement that can exacerbate pain symptoms in the abdomen is the movement of the abdominal muscles against resistance. In the recto-adductor syndrome, muscle contracture, localized in the adductor muscles, and both distal and proximal insertional pain can be detected. Moreover, muscle contracture can affect also the recti abdominis, and muscular trigger points can be found in the abdomen and in the thigh, in the adductors and in the gracilis. As far as the treatment with Hilt therapy of pubalgia is concerned, it begins by placing the lower limb of the patient in abduction and slight external rotation. Then the insertional painful points are assessed and, once they are detected, the initial phase starts by scanning first the contracted muscles and then the insertional painful points. Afterwards, the adductors and the gracilis will be scanned fast, covering the whole muscles. The rectus abdominalis is treated by fast longitudinal and transversal scanning movements. After that, treatment continues over the proximal insertion with transversal and longitudinal scanning movements. But we will also treat the distal insertion of the adductors and the gracilis. Finally, the insertion site of the rectus abdominis will be treated through transversal and longitudinal scanning movements. During the intermediate phase, muscle and insertional trigger points are treated directly. First, we detect the trigger points in the rectus abdominis. In the adductors, in the gracilis, and in the distal and proximal insertions of the adductors. Moreover, also the distal insertion rectus abdominis on the pubis will be examined. Then, still handpiece treatment on the painful point follows. We check then if pain has attenuated or has disappeared. When pain is reduced by 70 to 80%, treatment is performed over the remaining trigger points, if present. Then we treat the proximal and distal insertion. And also the insertion of the rectus abdominis on the pubic ramus. The final phase consists again of treatment by scanning. The scanning movement, though, will be slow, 50% slower than it was in the initial phase. We'll begin scanning slowly the muscle bellies of the adductors muscle and of the gracilis. Then we will scan slowly and longitudinally the muscle belly of the rectus abdominis. Then with transversal scanning movements. After that, the insertions of tendons will be treated with slow longitudinal and transversal scanning movements. The distal insertion and finally the insertion of the rectus abdominis on the pubis.